Did you know that a woman can only get pregnant a few days each month and that her body gives her clear signs of when those days are? This week on the Bioethics Babe Podcast, I sit down with Dr. Marguerite Duane, a board certified family physician and co founder of FACTS About Fertility, to unpack the science behind fertility awareness and restorative reproductive medicine. Dr. Duane shares how a night hospital shift changed her entire understanding of women's health, why fertility awareness is not the old rhythm or calendar method, and how tracking a woman's natural biomarkers like cervical fluid, basal body temperature, and hormones can empower women to understand their bodies and restore health naturally. If you've ever wondered how women's fertility works, or how technology and medicine are coming together for both men and women to revolutionize fertility care, you won't want to miss this conversation. Welcome to the Bioethics Babe Podcast, where we examine the tough questions in human flourishing in light of science, faith, and culture. I'm your host, Darina Grosso-Agnew. Now let's dive in. Today on the show, we're joined by Dr. Marguerite Duane, a board-certified family physician and co-founder and executive director of FACTS About Fertility, an organization dedicated to educating medical professionals and students about the science supporting fertility awareness-based methods and restorative reproductive medicine. She serves as an adjunct associate professor at Georgetown and associate professor of restorative reproductive medicine and director of the Center for Fertility Awareness-Based Education and Research at Duquesne University's College of Osteopathic Medicine. Dr. Duane cares for patients via a direct primary care house calls-based practice, MD for Life. She has served on the board of the American Academy of Family Physicians and the Family Medicine Education Consortium. Dr. Duane is married to a fellow family physician, Dr. Kenny Lynn, and they are the proud parents of 4 young children. Dr. Duane, it's such a pleasure to have you on the show. Welcome.
Thank you so much, Irene. I'm delighted to be here.
So let's start first with what first inspired you to pursue a career in family medicine and women's health?
Great question. I always like to say I received my call to medicine on November 2nd, 1979 at about 4:40 in the afternoon. And most people are like, how do you know that with such precision? And for me, that was a transformational moment in my life. I was just 8 years old and my mother gave birth to my baby sister at home. And I sat at her feet and watched my baby sister come into the world. And in that moment, I knew that I wanted to be a doctor. It was just incredible to see the birth of my baby sister. And so it's ironic that now, 40 plus years later, my practice is all about helping couples to have children and to care for patients in the comfort of their own home. My desire for family medicine was really rooted in my family that I grew up in and my own struggle with a chronic illness as a child. I'm recognizing how important the family is to a person's health, not only to our physical health, but our mental health and our overall well-being. So family medicine was always near and dear to my heart. And really by about 8th grade, I knew I wanted to be a family doctor as well. But I was always passionate about women's health. Again, I loved seeing the birth of my baby sister. I loved the idea of caring for pregnant women. And family medicine really provided the opportunity to do the full spectrum, to not only care for the women, but then to care for the children that they had, and also to care for their husbands, parents, siblings, etc. So providing care to the whole family through the full spectrum of family medicine is something that's always appealed to me, and it's always been a part of my practice. And I'm delighted to be able to care for my community of patients through MD for Life in this model.
That's amazing. Not a lot of 8-year-olds can witness a birth, especially a birth of a sibling. So that's an amazing experience for you. And obviously it's, as you said, shaped your life in such an amazing way and shaped your career.
And particularly amazing because my mother did this in New York, right? And she actually had an OB come to the home, which is unheard of in today's day and age. But I think that speaks to the power of my mother and her inspiration. She worked as a nurse for many years and really has been just an incredible inspiration and role model for my own career in medicine.
Beautiful. Well, tell us a little bit about your personal journey to become such a strong advocate for fertility awareness as well.
Happy to. And it's interesting because fertility awareness, female cycle tracking, natural family planning, these were terms that were completely foreign to me as a young woman, as a college student, when I was dealing with my own psycho-related issues. even as a medical student, I had never heard about these methods. It wasn't until I was in my first year of my family medicine residency at Lancaster General Hospital in Lancaster, Pennsylvania, when I was on OB call one night and doing what any good intern was told to do on OB call. I was getting all of my postpartum patients ready for discharge. And part of preparing our patients for discharge was to write their prescriptions for birth control, because it's really drilled into you as a physician. When a woman has a baby, she's getting ready to leave the hospital, you need to make sure she has birth control on board. So I was sitting there one night doing that when one of my senior residents, Dr. Pearl Huang Ramirez, decided to take that opportunity to teach me about the different forms of family planning, how they work, as well as the side effects that are associated with them. And we talked about in particular how in postpartum women, different forms of birth control could really adversely affect that postpartum outcome. Depo-Provera could cause prolonged bleeding. Combination hormonal birth control could affect a woman's milk supply and make breastfeeding more difficult. And as we talked through these, Dr. Huang then said to me, she said, "Did you know there are some forms of family planning that actually have no medical side effects?" And I thought to myself, what are you talking about? Like every form of family planning, has some side effects because birth control is designed to disrupt the way the normal reproductive system is designed to function, whether it's hormonal birth control, suppressing the natural production of hormones, Depo-Provera, again, being hormonal, altering that physiology. The IUD, when a woman has a plastic or metal device inserted into her uterus, causing like an inflammatory reaction, there's a whole range of side effects associated with these forms of family planning. And Dr. Huang said to me, she said, well, there are some methods of family planning that allow a woman to work with her body to understand where she is in, her cycle or in the phase of her reproductive life, so she can use the knowledge of her body to, plan for her families. And because you're working with the body, there are no medical side effects associated with this. It's like, what? What are you talking about? Like, what are these methods? And she went on to talk about in women who are postpartum and exclusively breastfeeding, you could use methods like the lactational amenorrhea method. She said in women, who were cycling, they could learn to chart biomarkers like cervical mucus and basal body temperature to identify when she's fertile and when she's not. And that night, like listening to those words had that same impact on me as watching the birth of my baby sister. It was transformational. Like I thought to myself, how have I never learned this? Like, here I am, a physician, family physician, passionate about women's health. Why have I not learned this? Where was this information when I was in medical school? How come I didn't learn this as a college student when I was struggling with my own psycho-related symptoms of painful periods? And why wasn't this offered to me then? Why didn't I learn about this when I was a 12, 13, 14-year-old girl just experiencing my cycles for the first time to better understand my body? And that shock quickly turned to anger. And that
Right.
anger is what really motivated me. I need to learn more. I need to understand these methods. And as I learned, the more I learned, the more I realized I need to share this with others, because this is something every woman and every person should know about their way their body works.
Oh, absolutely. And I had an experience when I was in high school where just my family physician, as they often do, they just offer birth control for as a solution for acne, and I didn't want that, so I refused that. But no one ever told me about fertility awareness based methods, and especially that, as you said, it's just even for being able to track your cycle is not necessarily to achieve or avoid pregnancy, but also to track your own health, to see,
Right.
are my cycles normal? Is there something wrong, or are they healthy? And so it's very important for any woman, regardless of where they are in their fertility, and also for different purposes. And so
Absolutely.
I ran through the same thing, and I'm grateful for your recommendation, because I ended up doing my training in FEM based on your recommendation, and I learned so much, and it's really important, and I love what you and FACTS do. So with that question, what gaps did you see in women's health education and care that motivated you to co-found FACTS?
Well, I think you already touched on a lot of issues. I mean, the way we are trained in medical school is that, no matter what the problem is that the woman has, the pill is the panacea for all that ails women, whether she has acne, whether she has irregular cycles, whether she has painful periods, whether she has PMS symptoms, whether she has postpartum depression. Hormonal birth control is often the first line recommendation for all issues that ail women. And what I learned early on in my residency after discovering fertility awareness based methods was that hormonal birth control doesn't actually treat the majority of these issues. While it may suppress the symptoms, it doesn't identify or address the root underlying causes, right? Take irregular cycles as an example. We see this a lot in young women, especially in girls soon after they start their periods. Within the first 2 years, it can be normal for a girl's cycle to vary such that she's not getting her period, but every month or every other month sometimes. That can be normal, but I see so many girls at 13 and 14 being put on the birth control pill because she's not getting her period every month. She's only getting it every other month. And so it must be irregular. And so they're put on hormonal birth control. And what that does is it doesn't regulate her period, as women are told, but it suppresses her normal cycle and gives her a regular withdrawal bleed every 28 days. And that is not addressing why is she having it. Maybe it is just a normal part of that physiological development, and her hypothalamic pituitary axis hasn't fully matured to allow her to start having regular periods. And her body just needs time to mature. I'll often use the example, the analogy of young boys, right? Like young girls, when they're going through puberty, their periods are starting to finally get into sync. Some girls, they'll go right into regular periods. Some girls, it'll take a little longer and they may have more fluctuation. We young boys, we see this in the change in their voice, right? Some young boys, as they're going through puberty, they'll go from talking like this to talking like this and like overnight. But some boys will kind of do this for like, a little while, and it sounds really awkward and uncomfortable. But that may just be a normal part of their development. And we just need to give them and their body the time to fully mature. As women get older, they may still experience irregular cycles, and the causes can be different. So polycystic ovarian syndrome is a very common cause of irregular cycles in women. It is also a very, very common cause of infertility. In fact, in women, PCOS and endometriosis are two of the leading causes of infertility. And so when women are experiencing irregular cycles due to PCOS, it is important that we identify that PCOS is the underlying issue. And how can we do that? By looking at her chart. In women with PCOS, they have ovaries that may be, or these multiple cysts in the ovaries that may be producing more estradiol, and she may have more mucus observations and more mucus patches on her chart, if you will. PCOS, although people think it's a reproductive health issue because the word ovary is in the name, polycystic ovarian syndrome, it's actually a metabolic disorder. And the way you treat it needs to be focused on addressing the underlying metabolic dysfunction. In contrast, another very common cause of irregular cycles we see in women is something called functional hypothalamic amenorrhea. This can be due to stress, this can be due to overexercise, this can be due to undereating. And with this, women will often have very long, dry cycles. And again, the way you treat it will be different than the way you treat PCOS. The way we're conventionally trained is if a woman comes in with irregular cycles, whether it's PCOS or functional hypothalamic amenorrhea, you just put her on the birth control pill. But that does not do women, that does women a disservice because you're not diagnosing and treating that underlying cause. So these were some of the gaps that I was seeing in medical education. But I was also seeing gaps in women who were looking for, family planning methods that did not have the side effects that are commonly associated with conventional forms of hormonal birth control. Women that had, ethical or moral concerns with using conventional forms of birth control like IUDs, that can have embryocidal actions, and they didn't want to take that risk, but they were not being offered other options to be able to address their family planning needs. And so I saw all of these factors, the family planning from a pregnancy prevention perspective, the family planning from an achieving pregnancy, right? If people present with infertility, commonly the only thing they're offered after ovulation induction medications is referral for IUI and IVF. But for many people, that's cost prohibitive. There are ethical concerns associated with it. and they want options that are going to get at the root underlying causes. And then in single women, whether they're teenagers or, perimenopausal, religious women, like every woman deserves access to this information to monitor their health and manage reproductive health concerns by identifying the root causes and treating the underlying issues. So I knew I hadn't learned about this in medical school. It was only by the grace of God that I had an encounter with a resident who was trained in these methods that taught me about this, that I realized we need to do something more. And that's ultimately what led to the foundation of FACTS. And I can speak to that more in just a minute. But before I do, let me just see if you have any thoughts or comments on everything I've already shared.
I think there's so much there that we're going to unpack. Really, the next question is about the foundation of FACTS and how you help med students, resident students, all of them with the organization and the mission that you founded. So let's go into that, and then we'll dive into the nitty-gritty of fertility tracking and hormones and contraception, et cetera. So, but first I would love for our audience to hear about what you do and how you serve the medical community.
Yeah. So, like I said, I first learned about fertility awareness based methods as an intern in 2000. It wasn't until 10 years later when I was on faculty at Georgetown University. At this point, I was adjunct faculty, meaning I was volunteering to teach students in the office and do small groups. One of my colleagues at Georgetown reached out and said, "Hey, we're looking for faculty to volunteer to teach small group classes to medical students on any topic related to medicine and healthcare." Georgetown has the philosophy of cura personalis, caring for the whole person. So they were really looking for content that would help their medical students learn to care for the whole person. And I was very familiar with the course that they were discussing, the selective. With the selectives, first year medical students could select from among 20 small group elective courses on topics loosely related to medicine. And I had actually taught one of these on breastfeeding, the basics and beyond, because breastfeeding is another topic we're not really well versed in. So when they reached out to me and said, "Hey, would you be willing to teach on a topic that would help make our medical students more well rounded?" I thought to myself, this would be such an incredible opportunity to even reach a small group of first year medical students and teach them about the different natural methods of family planning and how cycle tracking can be used to monitor health and whatnot. And at the time, I actually served as medical director of the Catholic Charities Health Centers in Washington, D.C. So I was overseeing 2 medical and 2 dental clinics. It was a 60 to 80 hour week job. I had 2 small children, a 3-year-old and a 1-year-old. So my life was very full. I didn't really have the capacity to necessarily create an entire new course. And so I thought about it, but then I was like, this is a great idea, but with what time? So I remember deleting the email from my colleague. And then a week later, she sent a follow up and said, "Hey, we're still looking for volunteers. If there's any way, you could teach something, we would really appreciate it." And I was just about to hit that delete button again, Arena, when I had this aha moment in this, like, no, if not now, when, if not you, who? And so I thought about it and I was like, okay, if I'm going to do this, I need help. And I ended up reaching out to people in the field of NFP and fertility awareness, said, "Hey, I have this opportunity to teach a small group of medical students. I don't know who's going to take the class. I don't know why, whether or not they're really interested, but, would you be willing to help me organize and teach this course?" And so long story short, I had that very first year, I had 8 medical students sign up for the class, which was great because you're limited to 5 to 10 students. So I was very happy we had 8 students. But I had 12 people teaching this class with me. So I'd reached out to all of these folks and I had the people that ran the Institute of Reproductive Health at Georgetown. I had Dr. Hannah Klaus, who is a leading educator in Billings and developed the Teen Star program. I had Dr. Richard Faring, who developed the Marquette method, fly in from Wisconsin to give an hour-long lecture on Marquette. And it was just incredible. And we had couples that were using these methods to share about their experiences. So it was really a wonderful experience. But the best part was the feedback from the medical students. They were like, "This is the best class I've had all year. This is the most clinically relevant information. This is something, why isn't this a part of our basic reproductive physiology curriculum? This is basic women's health." And then one student said, "This is something every medical student should learn." And I thought to myself, you're right. This is something every medical student should learn. And yet this content is not covered in the standard medical school curriculum anywhere at any medical school. That is until this past year. And so I saw I saw that as an opportunity, and I thought, you're right. How can we take this class that we're teaching 9 medical students and expand it and reach more medical students? So at the time, I was connected to Dr. Bob Motley, who is also a family physician. I was introduced to Dr. Motley through Dr. Ann Nolte, who is the founder of the Gianna Centers. And Dr. Nolte introduced Dr. Motley and I. And Dr. Motley was a family physician faculty at a residency program, really interested in bringing this education to the residents. I was really passionate about bringing the information to the students and the broader medical community. And so together, he and I collaborated and started FACTS, which initially was the Fertility Appreciation Collaborative to teach the science. And we were a collaborative project under the umbrella of the Family Medicine Education Consortium. At the time, I was on the board of the FMEC, and the FMEC is a larger secular medical education organization really designed to educate and support family physicians. And as the CEO used to say, to support the bright ideas of family doctors. And so I came to him with this bright idea. Hey, what if we taught medical students and family physicians about the female cycle and the science of tracking using natural or fertility awareness based methods? So on October 29th, 2010, FACTS held our very first meeting where we had 9 people come together: family physicians, fertility educators, residents, students, people that worked with Couple to Couple League, and people that were on the board of Planned Parenthood. So we gathered a diverse group of people that were passionate about educating women in the way their bodies worked. And that led to the formation of FACTS. And what began with 9 medical students or 8 medical students that first year, 9 people at our first meeting, has now grown into an organization that has educated thousands of medical professionals, not only all over the United States, but all over the world. And we've grown so much that in 2022, we formally became our own nonprofit and formally separated to become our own organization on January 1st, 2023. So now we are officially known as FACTS About Fertility, but our original name, the Fertility Appreciation Collaborative to Teach the Science, really highlights who we are as an organization. We want to highlight it's more than just an understanding and an awareness of fertility, but really an appreciation, because men and women are only finite for a short period of time in our lives, right? And we're collaborative. We will work with family physicians and OBGYNs and nurse practitioners and midwives and fertility educators. We will work with people from all walks of life, from all faiths. We work across medical education organizations and undergraduate organizations. We're teaching in nursing schools now as well. We really want to collaborate with everyone who's passionate about sharing the science and the evidence supporting fertility awareness based methods, right? So, fertility appreciation collaborative to teach the science. So, that's how we started. Those are our roots. And there's so much more for where we can go in the future and where we've come in the last 15 years. So we're really excited this year in 2025 to be celebrating our 15th anniversary as an organization.
Amazing. And can you tell our listeners in terms of how do you teach them? Do you teach them through courses, through webinars, in person? And if anyone who's listening wants to tune in, is it just for medical students, or can anyone tune in to one of these lessons, these classes?
Yeah, absolutely. So like I said, FACTS began with a small group elective for medical students back in 2000. Since then, we've grown exponentially. We started developing webinars or PowerPoint presentations that we would give, and we've trained over 100 speakers to give our FACTS presentations all over the world. And we had one of our students give a talk in Japan, which was amazing, at an Army base there. But we have our core webinars that focus on fertility awareness-based methods for family planning, the female cycle as a fifth vital sign. We have residents which are more geared for a medical audience, but anyone is welcome to register and attend, whether in person or they can register for live and recorded webinars via our website. And then we also have webinars that are geared specifically for a general audience. The Facts About Fertility Explained addresses both male and female fertility and is perfect for people that are engaged, young people that are interested in learning more about their body, couples that want to have a better understanding of the signs that they can learn to track to understand their cycles. And we also have a presentation for adolescents and their moms called Know Your Body, which really helps young girls understand and appreciate their period and what it signifies and how their cycle works and is this intricate orchestration of hormones that allows them to ovulate, which truly is a sign of health and that, can be observed through their period. So we've got our webinars, the elective that we started teaching to a small group of medical students in 2010. We have now expanded and is approved for credit through Georgetown University. So we can offer it to medical students and nursing students and other health professional students all over the world. So 2010, it was officially approved as a fourth year elective. So from January of 2018 through June of 2020, instead of just having 8 to 10 students a year, we were able to have 2, 3, 4 students a month. So in that first 2.5 years from January 2018 to June of 2020, we had 120 medical and nursing students enroll in our elective. Then, of course, we all know what happened in 2020 with the pandemic. Georgetown said they were going to cancel all away electives, including our elective, but I responded to the faculty at Georgetown saying, well, my elective was already offered online. And they're like, oh, well, great. Well, you can continue to offer your class. We won't cancel you or your elective. I'm like, no, you will not cancel me. And our elective exploded such that from September of 2020 to May of 2021, we had 225 medical and nursing students take the elective. So almost doubled the number of students in half the amount of time. Since then, we've now taught well over 1,000 medical students through our elective. But in 2019, we also started doing conferences. And initially, these were in-person conferences. And again, not only geared towards students, but really geared towards the medical professional community in general. OBGYNs, family doctors, pediatricians, internal medicine, psychiatrists, midwives, nurse practitioners, PAs, physical therapists, you name it, within the healthcare community, nutritionists, they've all engaged in our conferences. So 2019, we held 3 very successful conferences, and we were on track to hold a really big conference in 2020. Again, with the pandemic happened, we were able to pivot and able to offer virtual conferences. And so now FACTS offers an in-person and a virtual conference every year. We recently held our virtual conference. The theme was Lifestyle for Healthy Cycles, and that content will be coming out soon and offered through our online continuing medical education courses. So we realize people's schedules may not always allow them to join us live and or in person in real time for our virtual and our in-person conferences. So now we offer online continuing medical education courses. And again, while our content is primarily geared towards a medical audience or a student audience, we welcome anyone who is interested in learning more to enroll in our courses. So we have one part of our CME is focused on fertility awareness and Femtech and learning about the different devices. So if that's an area of interest to you, we invite you to register for Part F of our CME course. Part G really focuses on lifestyle and fertility awareness, how nutrition affects the cycle, sleep, exercise. So similar to what we offered in our virtual conference this past week, and we had people who do not have any medical background whatsoever enroll in both these CME courses and in our virtual conferences. So we offer so much content that is applicable for the medical community, but that would be of interest and really of value to people in the general community who really want to focus on the science supporting these methods and the value of cycle tracking and the way to address reproductive and women's health issues from a restorative lens.
Excellent. Well, those are really amazing resources. We're going to link to them on the show, and please look at the website. We'll talk about all of that and subscribe as well so that you can know what upcoming webinars are happening or conferences, etc. I want to dive into the nitty-gritty of all of these, and I think we just need to start at the very beginning because people have different varying levels of education on this, as you've expressed. Some people have never heard of this before. So let's start from the beginning. For people who may not be familiar, what exactly are fertility awareness-based methods? They're also called FABMs.
Right. So The term fertility awareness-based methods, or what these methods are, is these are ways in which women can learn to observe physical signs or biomarkers of their cycle that actually reflect the internal hormonal changes that a woman experiences on a day-to-day basis. The term natural family planning may be more familiar to many, and really the terms natural family planning and fertility awareness-based methods can be used interchangeably. The term NFP was actually first coined by the National Institutes of Health in 1974. And again, essentially means women can learn to observe their cycle to identify that window of fertility when a woman is capable of conceiving or becoming pregnant. Because the reality is in healthy, fertile women who are experiencing regular cycles, she is actually only able to get pregnant for just a few days out of the month. Like, one of the most common myths is that women can get pregnant any day of the month, and that's simply not true. In healthy women, they're only fertile for a short period of time. And when women learn to observe the signs of their cycle, they can identify that window of fertility. And couples can use that information to modify their behavior or to plan, their activity based on their family planning goals. So if a couple has serious reasons for wanting to prevent or needing to prevent a pregnancy, they would choose to not engage in sexual relations during that fertile window. Whereas if a couple is hoping to achieve pregnancy, they would really want to focus, their timing of sexual activity to coincide with that window of fertility to optimize their chances of getting pregnant in a given cycle. But what's important for people to know is even in healthy couples who have no underlying health issues, the likelihood of getting pregnant in any one cycle is less than 30%. Only 20 to 30% of the time will a healthy couple conceive when they have sexual relations during that fertile window. So again, with natural methods of family planning or fertility awareness-based methods, couples can observe specific physical signs or biomarkers, which include cervical mucus or fluid secretions, basal body temperature, and urinary hormones to identify where she is in her cycle and when her potential fertile window is, so they can then use that to monitor their health and or modify their behavior according to their family planning goals.
A lot of people who may not be familiar with fertility awareness-based methods might think of it as grandma's old calendar method, right? Can
Right.
you talk about how the calendar method is different? What we're talking about today, where we are in science and technology, how that's different from where perhaps this was decades ago?
Yeah. Fantastic question. It's interesting. And in 2012, one of the things that we did at FACTS, one of the first things we did was we actually did a survey of family physician residency directors and family physicians who were directors of women's health in their residency training programs. So these are the physicians that are responsible for teaching future physicians women's health and family planning methods. And we surveyed them about their knowledge and familiarity with modern natural or fertility awareness-based methods. And not surprisingly, but somewhat sad, the method that these physicians were most familiar with was the calendar rhythm method, which was like, oh, my goodness. I mean, in fairness, the calendar rhythm method has been around the longest. It was developed in the 1930s, so
Wow.
nearly a century ago, based on science that was done in the 1920s. So in the 1920s, there were two physicians, Dr. Ogino in Japan and Dr. Hermann Naus in Austria, who independently discovered that ovulation occurs about 12 to 16 days before the next menstrual period. And that was a major scientific advance at that time. I mean, prior to that, people didn't know, did women ovulate during her period? Did she ovulate every other day of her cycle? Did she ovulate in response to sexual activity? Scientists didn't know that until doctors Naus and Ogino discovered that women ovulated about 12 to 16 days prior to her next menstrual period. Using that information, an OBGYN, Dr. Leo Latz at Loyola University in Chicago, developed the rhythm of fertility and sterility method, which now is commonly referred to as the rhythm method. And this was a calendar-based method where he developed a formula for women to track the length of their 6 previous cycles and used the length of her 6 previous cycles to calculate the likelihood of the start of her fertile window and the end of her fertile window. And so basically, women were using retrospective data, that is the length of her 6 previous cycles, to predict her potential fertile window in her current cycle. Again, nearly a century ago, this was robust information. I mean, this was 30 years before the development of the birth control pill. So it was a major scientific advance. And in fairness to Dr. Leo Latz and proponents of the rhythm method, like, we weren't doing research at that time the way we do now in terms of doing, these well-designed, robust clinical research trials to measure the effectiveness. So the effectiveness was never really measured. It wasn't until the 1960s that the first modern methods were developed. And the very first modern method was the Billings ovulation method, which was developed by doctors John and Evelyn Billings in the early 1960s. Right around the same time that the birth control pill method was developed. And what the Billings discovered was that when women, during a cycle, a woman will produce cervical fluid secretions or cervical mucus, and this was an indicator of the changes in her hormones. And so now, instead of using retrospective data to predict future fertility, women were able to observe data in real time, her cervical fluid or cervical mucus secretions, to identify her potential fertility on that day. So it's like, I tell people, it's like, do you look at what the weather was last October to decide what you're going to wear today? Are you going to look at what the weather is today based on today's data, right? A year ago, it might have been like 80 degrees. And if you're using that data and you go outside and it's actually only 50 degrees, your body is going to be in for a rude awakening. So with modern fertility awareness-based methods, we use data that women observe in real time to identify her fertile window. So like I said, the Billings ovulation was the first modern method, but since then, the symptothermal method has been developed and refined. More cervical mucus-only methods have been developed, such as the Creighton model. Symptohormonal methods have been developed in which women observe not only cervical fluid or cervical mucus, but they also observe urinary hormone measurements, again, giving us more data to identify methods in real time. I think one of the things that's interesting, Arena, is a lot of people think there's only one natural method, but the reality is there are multiple methods. And sadly, most doctors are not at all familiar with this. And again, this is what inspired the formation of FACTS. And in 2010, there was a research study that was published in which they surveyed family physicians and OBGYNs about their knowledge and familiarity with modern natural methods of family planning. And in that study, in 2010, just 15 years ago when FACTS started, only 3 to 6% of the OBGYNs and family physicians were knowledgeable or familiar with some of the modern methods, including the Billings ovulation method, the symptothermal method, and the lactational amenorrhea method. So there is such a dearth of doctors and other medical professionals that are well-versed and knowledgeable in these methods, again, which is what motivated us to start FACTS and fuels our mission to this day. Our goal is that every community would have a physician that is trained in, a physician-led team that are trained in modern natural methods of fertility awareness and restorative reproductive medicine.
Absolutely. We need that because, as you said, most doctors are not familiar. And in fact, I would even warn our listeners, when you go on your phone app, a lot of the apps for tracking fertility still use the old calendar method. So be careful. Some of them are trying to predict your ovulation based on your last 6 cycles, and that will not give you the most accurate data for fertility. So beware of which apps you download, because some are using data from almost 100 years ago in the way that they operate.
And can I speak to that? Because FACTS actually did a research study specifically to look at apps that were being marketed to women to prevent pregnancy. So the study is now nearly a decade old. But we looked at the time in 2015, there were about 100 apps on the market that were being marketed to women to use to prevent pregnancy. We ended up excluding over half of the apps from our study because they were not based on a modern method. In fact, they were using a calendar algorithmic approach to, again, use historical data of the woman's cycling to predict future fertility. They were not using the modern methods. Of the nearly 100 apps that we reviewed, there were only 10 that we could recommend based on the fact that they were using a modern evidence-based method and they were accurately predicting the fertile window. I can certainly share the link to a summary of that study. But the other thing I tell people, like, I think apps can serve as a terrific tool to facilitate tracking your signs. But I always like to tell women, you are smart. You are smarter than your smartphone. Don't let your phone tell you when you may be fertile. Learn how to observe and interpret your signs, and you be the judge of whether or not you may be fertile. You can certainly use an app to track and record your signs, but don't let your app tell you if you're fertile or not. Use your own knowledge and experience. And this is where working with trained instructors is really important. And, this is another important point to make. A lot of women are tracking their cycles with an app and think they're using a natural or fertility awareness based method, but they're not receiving appropriate instruction. And so if they're not learning how to make the observations correctly and not accurately tracking the data, bad data in is going to give bad data out, and you are going to be at higher risk for an unintended pregnancy. And my concern, and part of why FACTS did this study 10 years ago, is we didn't want, women tracking using apps and saying, well, I'm using a natural method and natural methods don't work. Well, they work when you learn them from trained instructors. And so on our FACTS website, we actually have a directory, a physician clinician directory of fertility awareness educators and clinicians that are trained in these methods.
Excellent. That was going to be my next question. If you can remember, can you name at least the top 3 apps that are your favorite? And we will link to the top 10 that you mentioned. But just to give people an idea of what to download, which ones you recommend of all the apps that are out there.
So it's funny because I recommend different apps for different reasons, right? So when it comes to preventing pregnancy, the NFP Billings app, it's called NFP Charting, that ranked, we actually had to divide them into 2 categories because some apps would predict the fertile window, some didn't. I mean, many reporters I spoke to thought like, oh, it's better if the app predicts the fertile window for you. I'm like, no, it's actually not. It's better for the woman to learn herself. And so it depends on the classification, but like the NFP Charting app, I know was a good app. Sympto.org was a good app. Now, when it comes to recommending apps, again, it really depends on the audience that I'm targeting and what they're using the app for. A lot of the patients that I'm seeing are learning to chart to address women's health concerns or to deal with infertility. And so not only do I want to look at their biomarkers, what does their cervical mucus look like? What about their basal body temperature? I also want to look at their symptoms. I want to look at their medications. So probably my favorite app in that regard is the Chart Neo app, which was developed by Dr. Phil Boyle, who developed the Neo fertility method. So I really like the Chart Neo app for people that are using apps from a more of a medical management perspective. For young people, for people that really want to use it from a health monitoring perspective, I really like the FEM app because it gives a lot of good information back to the woman. There's also the Peak Day app that I think is also very helpful and can be very useful as well. But when it comes to apps that women are using to prevent pregnancy, again, I still would go back to the 2015 study that we referred to. But again, I would also encourage people to beware when you're using apps. Another app that I really like for young girls is an app called Read Your Body. And what I like about the Read Your Body app is that your data lives on your phone. It doesn't live in a cloud. And that's an important thing to note because a lot of people will choose an app because it's quote unquote free. But let me tell you, no app is free. If you're not paying for the app with your money, you're paying for it with your data, in that the app developers, the app companies may be selling your data. And that's what I like about the Read Your Body app is that they do not have your data. Your data lives on your phone, and so they don't sell your data. So again, I really encourage people to proceed with caution. There are definitely some apps that I don't recommend. One of the most popular apps is the Flow app, and I really do not like that app. And there are others that I think just have some concerns associated with them. Like we had talked about, some that really are calendar tracking apps disguised as apps that are allowing you to track biomarkers because you put in your biomarkers, your temperature and whatnot, but it then completely ignores that. ignores that information. So yeah, I get this question a lot. It's kind of like the question I got, like, which is the best natural method of family planning or fertility awareness-based method to use? Like, which is the best app? My response is always, it depends. It depends on the person. It depends on their reason for using a method or an app. And so this is where working with a trained educator or, again, our FACTS webinar, the Facts About Fertility Explained, we really walk through how to choose which method might be best for you. And we're always happy to talk about like which app may be the best for you as well.
Thank you. That's super helpful. I want to dive a little bit more into the biomarkers because this may be the first time our audience is hearing about this. What do you mean cervical mucus? What is basal body temperature? How do you actually monitor your hormones? And so, if you can walk us through each of those. So, if you were going to check your basal body temperature, what does that entail? If you were going to check your cervical mucus, what does that entail? Or your hormones? And what's crazy is that uh, people who, because we haven't been taught this in middle school as we should, right? When they're doing all the talks about you're getting your period, etc., women think that cervical mucus might be a sign of disease instead of health. And so they don't understand what all of that means. So can you talk about that and also just dispelling the unknown factor of, well, how do you even check cervical mucus or all of that?
Yeah, no, absolutely. I'm happy to walk through, but with the disclaimer, like I'll give you a lot of information. But again, if you want to learn to chart your biomarkers, definitely learn from a trained instructor. And let me just start with a story because you mentioned like a lot of women think that cervical mucus or cervical discharge may be a sign of disease. That's absolutely the case. I will often share the story of a couple that came to me because they were struggling to get pregnant and they were young, they were healthy, they were at the prime of their fertility. Like she was 27, he was 30. She had very regular, healthy cycles. He had a child from a previous relationship. And so they couldn't understand what was wrong. Why weren't they getting pregnant? And the wife confided in me that she was concerned that she had an infection. And she described to me that every month or almost every month, she would get this recurrent discharge. It would usually last for a few days. And every time she would experience, this copious amount of fluid discharge from her vagina, she would say, I won't have sex with my husband because I don't want to give him whatever it is that I have, thinking that this was a sign of disease. And what she was describing, I did a very careful, detailed menstrual cycle history. What she was describing was her normal fertile cervical fluid that rises as a woman is entering her fertile window. Now, I did testing and we did rule her out for, any sexually transmitted disease. And I explained to her the discharge that she was noting was not a sign of disease, but actually was a sign of health and a sign of her fertility and that she was approaching ovulation. And I said, humor me, please. The next time you have this discharge or this mucus or these fluid secretions, have sex with your husband. I can guarantee you the only thing that you will give him is a baby, potentially. And they conceived after 2 months and they thought I was a miracle worker. And all I really did was explain to them how their cycle worked. They had been trying for over a year. So they technically met the definition of infertility, but they were showing how effective these methods could work when you avoid having sex during the fertile window because they had successfully not conceived, right? Sometimes some basic information can go a long way. That being said, a little bit of information without the full context can also potentially be harmful. So again, I'll walk through the different biomarkers, but I encourage your listeners, if you want to learn more, visit the Facts About Fertility website, our physician, clinician, educator directory. We link to all of the modern methods and their teaching directories. So please look at our website, factsaboutfertility.org for this information. But let's dive into the biomarkers. So the first biomarker I always like to talk about is cervical mucus or cervical fluid secretions. At FACTS, we tend to use the term fertility awareness-based method as opposed to natural family planning because we want to highlight this is so much more than just a family planning method, right? It's really about being aware of your fertility and the way your body is designed to work. Similarly, we like to use the term cervical fluid secretions as opposed to cervical mucus because oftentimes people associate mucus with infection. And oftentimes, normal, healthy, fertile cervical fluid secretions will be very liquidy and watery, and it's not going to be a thick type mucus. So cervical fluid secretions are produced in the glandular cells of the cervix. So for those of you that may not understand female anatomy, the cervix is the neck of the uterus. It's the lower part of the uterus that really is the opening into the uterus. And in the glandular cells of the cervix will produce a fluid or mucus type secretion. And the type of secretion will vary depending on the hormones. So when a woman's hormones are really low in the beginning of cycle, she likely will not notice any cervical mucus or cervical fluid secretions. She may just notice that she's dry. But as a woman's estradiol is rising, the estradiol acts on the cervix to produce cervical fluid that is very thin, watery, stretchy, slippery. It's often like a raw egg white, right? So if you've ever cracked open an egg and you see how it's very clear and slippery and watery in sensation, that's the type of mucus that is produced under the influence of estradiol. Now, how does a woman check for cervical mucus? Well, first and foremost, she does not check it at the cervix, okay, to be very clear. It's actually very easy to check for cervical fluid secretions. And part of it is just being mindful, right, of the sensations we feel in that area as we go about our day. But the best way to check, and this is what I advise women, is every time you go to the bathroom, before you actually begin to go to the bathroom, we encourage you to wipe with toilet paper from front to back. And pay attention, how does that toilet paper feel when I move it from front to back, from the vulva or vaginal area down towards the rectum as it crosses that skin in between, which is known as the perineum? What does that feel like? Does it feel dry? Does it feel moist? Does it feel wet? Does it feel slippery? With the Billings ovulation method, they actually teach women to really pay attention to the sensation because that is the most sensitive indicator of cervical fluid. So the first thing you do is you pay attention to what is the sensation. Then you'll pick up the toilet tissue and observe or look at the toilet tissue to see if there is any secretions or mucus on the toilet paper. If there is a significant amount, or if you notice as you're pulling the toilet paper away, the mucus stretches, you may want to actually pick up the mucus and finger test it to see, is it stretchy? And if so, how much does it stretch? Sometimes it can actually stretch up to an inch, right? I have had patients come into me thinking, again, that they have an infection or that they're incontinent because they feel like they've wet themselves for a few days, but really that may simply be a sign of their estradiol. So we teach women to pay attention to the sensation in the vulvar area throughout the day. And every time they use the restroom and before they shower in the morning, to wipe from front to back, pay attention to the sensation, observe to see if there's any mucus, and finger test it. So it uses the acronym SOFT, SOFT. With the neofertility method, they use the acronym WIT. Walking, what is the sensation when you're walking? Wiping, what is the sensation when you wipe? Inspecting, looking at that toilet tissue, and then testing to see if there's stretching. So depending on the method, they may use a different acronym to teach you how to observe cervical fluid. Again, under the influence of estradiol, which is rising as you're approaching ovulation, mucus will be more slippery, stretchy, or watery in sensation. Now, once estradiol reaches a certain threshold level, that will trigger an LH surge or a luteinizing hormone surge. And it's the LH surge that actually triggers ovulation or release of the egg. And it's the release of the egg that we need to occur in order for pregnancy to occur, because without the egg, fertilization cannot occur. So once the LH surge happens and the egg is released, the egg is available potentially for fertilization. But that remnant follicle, that follicle that contained the egg that burst to release that egg, that remnant follicle then forms what's called the corpus luteum. And what's amazing, and I love sharing this with women, is that every cycle, our body develops a new endocrine organ, the corpus luteum, which will then continue to produce estradiol, but will also produce progesterone. The body produces progesterone in the second half of the cycle, and the luteal phase after the luteinizing hormone has resulted in rupture of that follicle, and you form the corpus luteum. So the progesterone rises, and the progesterone then acts on the cervix and also changes the cervical fluid secretions such that the mucus is much more thick or sticky or becomes very dry. So women will notice a distinct change in the cervical fluid secretions under the influence of estradiol to the production of cervical fluid under the production of progesterone. Some women will note that they get very, very dry right away. And this is a very clear indicator that ovulation has occurred. Now, the peak day is the last day of fertile type mucus. That is mucus that is clear, stretchy, or lubricative, or it's that last day when there's that distinct change in sensation from very slippery or lubricative to very sticky or tacky or dry. The peak day is the best marker that a woman can observe to indicate that ovulation has occurred. But we know that ovulation occurs within 2 days of peak. So this is why that identification of that fertile window may vary. And this is why it's so important that women are working with trained instructors to really help them to identify, observe, and interpret those observations. So that's the first biomarker.
Before we go into the next one, Dr. Duane, I wanted to make sure there was a lot there. And so I just wanted to go through a few things before we move on to the next
Sure.
biomarker. The first one is, obviously, so you mentioned that cervical fluid is different during the fertile window than during the infertile window. Why is it that cervical fluid is thin, stretchy, egg-like? How does that help fertility? Second question is, you mentioned that it's also an indicator that LH surge will happen when LH surge happens. It's an indicator that ovulation will happen soon. So how long after the LH surge does ovulation happen?
Great question. So let's tackle the first one. Why is cervical fluid important that it's clear, stretchy, slippery? What is its function? I want your listeners to walk away with this quote. Cervical fluid is the elixir of life. Now, what does that mean when I say it is the elixir of life? Without healthy, fertile cervical fluid, most of us would not be here today. And this is why. In the absence of fertile cervical fluid, sperm will die within the woman's reproductive tract within 6 to 12 hours. That's right. Sperm will not survive more than half a day in a woman's reproductive tract in the absence of fertile cervical fluid because the woman's vaginal tract is a very hostile environment for sperm. It sees sperm as a foreign body. But in the presence of fertile cervical fluid that is produced under the influence of estradiol, sperm can survive for up to 5 days, okay? So we're talking a difference in lifespan of 6 to 12 hours to 3 to 5 days under the influence of that fertile cervical fluid, which is the elixir of life. That fertile cervical fluid plays critical roles in fertilization. There are different subtypes. There's the L subtype that I like to teach my medical students, trap the loser sperm. So if a man has defective sperm, two-headed sperm that swing around in circles, we don't want defective sperm fertilizing the egg. So the L-type mucus will trap the loser sperm and prevent it from proceeding forward. Then you have S-type cervical mucus that is designed to nourish and support and strengthen the sperm for that long swim to find the egg. So fertile cervical fluid, the subtype S, helps the sperm to survive up to 5 days prior to ovulation. And then there's a third subtype, P-type cervical fluid, again, all produced under the influence of estradiol that is released right before ovulation that helps to propel that sperm forward into the uterine cavity, into the fallopian tubes in search of the egg. So the fertile cervical fluid that's produced under the influence of estradiol and the subtypes are critical for sperm survival and really serve as the elixir of life, because if the sperm cannot survive long enough, it cannot fertilize the egg. If it doesn't fertilize the egg within the 12 to 24 hours after the egg is released, there would be no baby. Most of us would not be here. So I am serious when I say that the cervical fluid is the elixir of life. Now this gets to the next question. Cervical fluid is often produced days before you get that LH surge. So that's an early sign for couples that are trying to get pregnant that you are entering the fertile window. When a woman has the LH surge, that's a sign that ovulation is likely to happen within the next 12 to 24 hours. And once that egg is released, the egg will only survive for 12 to 24 hours. So in couples that are trying to get pregnant that are just using LH test strips, I often tell them, like, if you're testing in the morning and it's positive in the morning and you wait until that night to have sex, it may be too late, right? You really want to learn to observe cervical fluid and to help in terms of conceiving. And as soon as you observe the cervical fluid, that's the best time to begin engaging in sexual relations. Because once the LH surge happens, the egg will be released within the next 12 to 24 hours, and then the egg will only survive for another 12 to 24 hours. So you're really looking at a very narrow window of time of about 48 hours after the LH surge for pregnancy or conception to occur.
I think that's super important information for everybody. And I've also been taught that obviously if you have cervical fluid, it's like a highway for the sperm. It creates a
Yep.
highway for the sperm. And if you're dry or have a different type of cervical fluid that is not the kind that is fertile cervical fluid, it will block the sperm's way. It'll
Yep.
kill them, block them.
I like to say the cervical fluid produced under estradiol creates swim lanes, right? You can think of it as a highway, but it's also like swim lanes that allow the sperm to swim right through. But the cervical fluid produced under progesterone forms this very thick, coagulable mesh-like net that's designed to block anything from getting in, right? Whether it's additional sperm or potential, viruses or other sources of infection. Why? You want to block anything from getting into that uterine cavity, because if you have the creation of a new human life, you've got fertilization of the egg and the formation of a human zygote. That human zygote will rapidly divide, forming a blastocyst and a morula and an embryo that will then implant into that uterine cavity. And you want to keep that uterine cavity as sterile an environment as possible, so that the progesterone produced after ovulation is designed to block any additional foreign bodies from entering into that uterine cavity, creating a protective environment for that newly formed human embryo to hopefully implant and continue its life's journey.
Yes, it's so amazing. You can actually see this, observe this under a microscope. If you look at cervical fluid from the different parts of the month under a microscope, you will see those lanes, lanes. You will see the mesh netting. It's amazing. That's science, and it's amazing that you're teaching this to not only the med students, residents, but to the general public, because it's important information that
And
is
again,
not known.
It's information for everyone. And that's like FACTS is focused on sharing the science, right? I realize, one of the myths around, fertility awareness-based methods or natural family planning, one of the running jokes is like NFP stands for not for Protestants, because this is a Catholic thing. And the reality is nobody's ovaries are Catholic, right? Every woman, every biological female deserves this information about the way her body works. And so that's why at FACTS, we are focused on sharing the science. And fertility awareness-based methods, restorative reproductive medicine, are based on solid scientific evidence, both basic and clinical science, that demonstrates the effectiveness of these methods from a family planning as well as a health management perspective.
Excellent. Well, we should move on to the basal body temperature. Let's go through that one and hormone monitoring.
So with the basal body temperature, women check their basal body temperature every morning. It's the thing that they do first thing as soon as they turn off their alarm, before they even get up and out of bed. They want to put a thermometer, basal body thermometer, in her mouth to check her temperature. It's important that women are checking their temperature at the same time every morning and before she gets up and starts moving around. It's what is the baseline before any activity has occurred. And what women will notice is in the first half of her cycle, before ovulation occurs, her temperature will be about a half a degree lower. Once ovulation occurs, with that rise in progesterone, it actually causes a rise in the basal body temperature by about a half a degree. And that's confirmation that ovulation has occurred. Now, normally after about 12 to 13 days of an elevated basal body temperature, the temperature will start to drop. And as soon as you see that drop in temperature, that's a clear indicator that your period will likely begin in the next day or two. So I don't know about you, Arena. I don't like to be surprised about when my period is coming. And I think most women would like to know when it's coming. If you're tracking your temperature, you can monitor and see that drop in temperature and know, like, okay, this is a sign my progesterone is dropping. This is going to lead to the triggering of the release of that uterine lining and the start of my menstrual period. So it doesn't come as a surprise. But the other thing that the basal body temperature can be used for is if you're tracking your basal body temperature after ovulation and you see it rise, if it remains elevated for 16 days, that's a clear indication that pregnancy has likely occurred and the body is continuing to, that newly formed embryo is stimulating that corpus luteum to continue to produce progesterone to maintain that pregnancy. So it's an incredibly helpful biomarker, not only from a pregnancy prevention standpoint by helping give women that added benefit of confirmation that ovulation has occurred, but it can be a valuable tool in predicting the onset of your period or to identify that pregnancy has occurred to more accurately date a pregnancy, which becomes really important later on when it comes to end of pregnancy management and hopefully preventing preterm labor or preventing a post-dates delivery, guiding appropriate indications for induction of labor if that's necessary.
And in fact, with basal body temperature, you might actually know you're pregnant before a pregnancy test even shows positive. If you're
Absolutely.
tracking your basal body temperature and trying to get pregnant, that is another sign that you are, even before you get anything on that pregnancy test strip.
It's interesting because with fertility awareness-based methods, it's funny, in one of the handbooks that most medical students carry around, it talks about the different forms of family planning, including fertility awareness-based methods. But it lists as one of the disadvantages of the method is that it requires communication and cooperation with your partner. And I'm always like, why would that be a disadvantage if like you're cooperating with your partner and like planning your family? You would think that this would be a good thing. And I often hear stories when couples use the symptothermal method. And this was even my own case when my husband and I were using it early in our marriage. Like he would be the one recording the temperature. I was not a morning person. I was terrible at even remembering to take my temperature. So, my husband would often write it down. But and a lot of I've heard cases of couples that are using the symptothermal method, and the husband will look at the chart and tell his wife, "You're pregnant." She's like, "What? How do you know?" She's like, and he's like, "Well, I can see your temperature is still up. We're pregnant," right? And it's like,
Wow.
it really shows like this really is a couple's issue, right? Like having a baby, not having a baby, this is not a woman's health issue. This is a
Mhm.
couple's issue. And that's the beautiful thing about these methods. I don't see it as a disadvantage, but I see it as a huge advantage because it really does engage men back in the conversation of family planning such that women don't bear the brunt of responsibility themselves, but it's a shared responsibility.
Yes, and it's a shared fertility because you can't
Mhm.
have a baby without the other. And so talking about these fertility biomarkers is super important and super helpful and actually brings couples together, makes them closer
Mhm.
because they're understanding their own fertility as a unit as opposed to independently from each other.
Right. And I'll talk about the next biomarker, but I also want to make sure when we touch on infertility, you're talking about shared fertility as a couple's issue. Infertility, we have to
Mm.
also have to recognize that it's not typically just a woman's issue, but it can also very much be a man's issue too. But let me touch base on the last biomarker, which are urinary hormone measurements. And so to measure your urinary hormones, it's a fairly simple process. In most cases, women will, the first morning pee in a cup and they'll take a dipstick and dip it in the urine. Depending on the monitor that you're using, you may actually have a monitor that you insert the stick in. Some of the test strips actually have an app where you will take a picture of the test strip. Test strips now, many people often think of LH test strips to identify that LH surge. There are plenty of test strips to do that. But there are now test strips that not only check LH, but estradiol, so the clear blue fertility monitor, which is used in the Marquette method, uses the clear blue monitor, which measures both estradiol metabolites and LH. But there are other monitors that can also measure progesterone in the urine as well as LH hormones. Again, can be fairly complicated. So if you want to learn how to monitor your urinary hormones, I strongly encourage you to work with an instructor that is trained in teaching women how to observe their hormones and how to interpret that. Again, the Marquette method is probably the most well-researched symptohormonal method in which women learn to track hormones. Other methods like FEM may also add in urinary hormones and neofertility, but it is also a very valuable biomarker for women to observe. it's nice, and it's similar to the symptothermal method with the basal body temperatures. It can add that cross check, right? So you may be observing cervical mucus to identify that beginning of the fertile window, and then either the basal body temperature or the urinary hormones to measure the end of the fertile window. The difference with urinary hormones is with the basal body temperature, you typically need to check your temperature at about the exact same time every day, whether it's weekday or weekend. So if you're getting up every morning at 6:45 during the week, 6:45 on Saturdays and Sundays, you still need to check your basal body temperature at that same time. Whereas with urinary hormones, it's the first morning urine and it's typically within a 4-hour window. So it gives a little bit more flexibility. But for those people that like to dot all their I's and cross all their T's, it can be a nice secondary check for women and couples to learn to observe.
And there are other monitors too now on the market, like Anido or
Hmm.
Mira, and they check 4 of the hormones. They check
Yep.
LH, FSH, estradiol, and progesterone. And so that's
Yep.
super useful information. It charts it for you once you plug it in. It charts it for you, so you can bring that chart along with any other charts that you've been using with any of the apps to an instructor or to your doctor if your doctor's trained in understanding these methods and help make sense of it if you are trying to get pregnant, etc., or you're just trying to track for your own health. I wanted to make a note that there's a BBT. So for your basal body temperature, there's a specific thermometer. Why use that as opposed to any other thermometer?
Yeah, so with the basal body thermometer, it's going to be more specific. It's going to give you a more exact temperature. And that's important because we are trying to just detect a half a degree range in temperature. The other thing is the normal thermometer may not have as wide a range. And so you may miss some of the lower temperatures. And if a woman is having consistently low basal body temperatures, that can again often be a sign of underlying illness that if a physician is trained to interpret, may be able to identify another underlying health issue. In terms of the urinary hormone monitors, yes, there's the Clear Blue, Anido, Mira, Proof test strips also have different versions where you can check FSH, LH, estradiol, and progesterone. I will say, other than the Clear Blue monitor, most of these monitors have not yet been well studied, although there is ongoing research. My colleague, Dr. Thomas Bouchard, is doing lots of research right now with Mira and Anido. And again, in part F of our FACTS online educational course, it's part F for Femtech. We actually teach about a lot of these different monitors and talk about the evidence that exists right now to support their use. So if somebody, really wants to geek out and do more detailed research or learning, we definitely recommend they check that out. And I would also say, like, well, you may be super enthusiastic about your chart and everything it shows. You may bring it to a doctor, even a doctor that is like trained in one of the restorative methods like Creighton or Napper, and they may like, I'm not sure how to interpret this, right? Because not all of the methods will use urinary hormone monitoring. And so your doctor may not be well versed. I encourage you to not be discouraged. And this is what I encourage the students and the physicians that we work with. If you don't know the answer, if you're not sure how to interpret, ask your patient because patients really are experts in their own bodies. So rather than dismiss it as like, well, I don't know how to read that, say, can you explain to me, what this means? What is this line? Oh, okay. Is there any more information that you have that I could read? Or better yet, refer your physician, to the FACTS website to learn more, because our goal is to educate as many medical professionals as we can so they can better serve the patients that need this care.
Absolutely. And another note about these fertility monitors, I use Anido. Just keep in mind that for hormone tracking, they measure urine metabolites. If you go and get blood work done, those are going to be different levels and different numbers, and those are more accurate. But it's nice to have something at home that at least gives you a sense of where your hormones are, even if you don't have a blood test. As you may want to speak about, Dr. Duane, there are a lot of blood work tests that people can do, especially if they're looking to get pregnant, etc., to check all of their hormone levels. Now, this is the big elephant in the room, right? People will ask this, and this is probably the first question you'll get concerning fertility awareness-based methods. How effective are each of these methods compared to hormonal contraception or other forms of birth control?
Yeah, great question. Before I get into the comparison, let me just start with, in order to use these methods effectively, there are really three things that you need to do. or you need to have. The first is you need to learn these methods from trained instructors, because the studies of the effectiveness of these methods, almost all of them were done when women learned from trained instructors. So that's really important. Next is you have to be motivated to use these methods, because these methods do require that every day you're making observations and you're taking the time to interpret it, and you're motivated. If your goal is to avoid pregnancy, you're motivated to avoid having sexual relations during that fertile window. And the reality is that can be challenging to abstain from sex during your fertile window, because in women, that's when our estradiol is highest. That's when our libido is the greatest. That's when we are physically most attractive to our partner, right? Like, we were designed to reproduce. And so like our natural desire is to come together, during that fertile window. So it really does require some self-control, right? And so you need to be motivated to make the daily observations, to interpret them. And if your goal is to prevent pregnancy, to avoid sexual relations during that time when your sexual desire may be at its highest. And in that regard, the third thing you need is you really need support of your partner, right? Because this isn't something, again, women do on our own. This is something that, we need to be having conversation and communication, with our partner about, where we are in terms of our family planning. And this can be challenging because the reality is like, I don't know about you, but like, I'm not exactly the same as my husband. In fact, we're complete opposites, right? Not only in our personalities, but we can be complete opposite in our level of desire, right? One spouse may really, really want to have a child. One may be like really reluctant. And so, if you really want to use this method effectively to prevent pregnancy, you really need to be more conservative. So you may be less willing to take chances, so to speak. And again, from my own personal experience, there was a period in our life where my husband and I had very serious reasons, to prevent. So we were much more conservative in the use of the rules. But there were other times when we were definitely more open. And while we might not have been actively trying, we were like, if it happens, it happens. So our motivation to prevent was really low at that point. And so we weren't as strict in terms of following the rules. But to use a method effectively, you need to learn from a trained instructor, be motivated, and be on the same page with your partner in terms of, what your family planning goals are. So when it comes to effectiveness of natural methods, with perfect use or correct use, and let's face it, none of us are perfect, but with perfect use, almost all of these methods are more than 99% effective. But it's not really fair to say perfect use, because nobody's going to use anything perfectly. So you really do need to look at the typical use of these methods, and it will vary. So depending on the method, based on the highest quality research studies, the typical use effectiveness of these methods can range anywhere from 86 to 98% effective. So methods like the 2-day method or the standard days method, which is a simplified calendar-based rhythm method, and the 2-day method is a less detailed cervical mucus method. Those are in the high 80s in terms of effectiveness rate. You're not getting as much information. It's not as detailed. Whereas with the symptothermal method, where you're tracking mucus and temperature, the effectiveness rate with typical use, learning from a trained instructor, is about 98% effective. So, these methods can be very effective. How does this compare to conventional forms of birth control? Well, the IUD, which is the number one primary recommended method of birth control to most women, has very high both perfect and typical use effectiveness rates, 99% with perfect and 98 to 99 with typical use. But part of that is with an IUD, a woman has an IUD placed and it stays there for 5 years and she doesn't have to do anything about it, right? It's a set it and forget it. But a lot of women find it's really hard to forget because they are suffering from side effects, spotting, pain, discomfort with sexual relations, right? So while it may be more effective, there's more risks and side effects associated with it. And if a woman is not happy with the IUD, she's not in control, right? We talk about birth control, but she's not in control because she can't remove the IUD. She's dependent on going to a doctor, to do that. With behavioral methods of conventional forms of family planning, what do I mean by behavioral methods? Like methods like the birth control pill or condoms, where women have to engage or men have to engage in a behavior to use the method effectively. Obviously with birth control pills, women need to remember to take that every day. with condoms, men need to remember to, have them, and put them on. Their typical use effectiveness rates are on par with conventional forms of family planning. Like, condoms are anywhere from 82 to 85% effective with typical use. Hormonal birth control pills are 90 to 92% effective with typical use. So again, comparable to fertility awareness-based methods, but what sets fertility awareness-based methods apart is there are no medical side effects. Even the World Health Organization recognizes that fertility awareness-based methods are the only form of family planning with no medical side effects. Concomitantly, the World Health Organization also recognizes that combination hormonal birth control pills, that is birth control that has estradiol and progesterone, synthetic estrogens and progestins to be clear, because hormonal birth control does not contain the normal hormones that a woman's body produces. It contains synthetic versions, which is what leads to so many of the side effects. But the World Health Organization recognizes combination hormonal birth control pills as being a class 1 carcinogen. That is the highest level of cancer-causing risk. That is, hormonal birth control is in the same cancer-causing category as cigarettes, as asbestos, right? So why? Because combination hormonal birth control significantly increases a woman's risk of breast cancer, cervical cancer, and liver cancer. These are very prevalent cancers that affect hundreds of thousands of women all total. Now, physicians will say, but hormonal birth control can reduce the risk of ovarian and endometrial cancer. And while that may be true, the incidence of those cancers is so much less that the actual number of people being affected is still far greater, with an increased risk of breast, cervical, and liver cancer. Not to mention, a woman can also reduce her risk of ovarian and endometrial cancer through pregnancy and breastfeeding, which, certainly with breastfeeding can have many other health benefits for women. So there you go. That's a little bit more about the effectiveness.
Mind-blowing information for our listeners. And just to repeat, fertility awareness-based methods can be, with typical use, can be as effective as from 86% to 99%, depending on the method. Whereas hormonal birth control, is 90 to 92% effective, and condoms are 82 to 85% effective. IUDs are 99% plus.
Yeah.
But as Dr. Duane mentioned, your body is continually being exposed to all of these hormones, these synthetic hormones, and you don't have much control over what's happening since it's in your body, and you have to go to the doctor to take it out.
Yeah.
But how many of us are health conscious and want to avoid any kind of hormones in our chicken or in our milk or anything else we buy from the store? And think about that dichotomy between the hormones we avoid because they're dangerous to our body in the food we eat, and the hormones that women are exposed to with hormonal birth control.
And to be clear, I mean, there are some IUDs that do not contain hormones, like the copper IUD, but this still has a whole host of side effects because it can lead to copper toxicity. And not to mention, with an IUD, it's literally a metal or plastic device in the shape of a T that is inserted into the woman's uterus. So we are literally putting a foreign body into the woman's uterus, her womb, where hopefully at some point, if she gets pregnant, her child will grow. And when you have a foreign body, like if anybody's had a splinter, you notice like the skin around gets all red and inflamed. That's what you're doing when you have an IUD in your body. That is what's happening, is it's creating a chronic inflammatory response because you have a foreign body that has been inserted and is expected to remain for the next 5 to 10 years. Now, we live in a free country, and that's a beautiful thing, that we have the opportunity to make the choices about what we want, for our health. But from an ethical perspective, and since this is an ethics podcast, I want to speak to the ethics of full informed consent, right? Like, women should be allowed to choose what is best for them, but they need to be given full informed consent about how the methods work, the side effects and risks associated, and the effectiveness, and other options. The reality is that the overwhelming majority of women are not given this information by their doctors because their doctors simply do not know, right? Or sadly, patriarchally, doctors think that they know better for their patients and are going to say, well, that young woman can't really control herself, so we really need to control her fertility for her by placing the IUD. That is disempowering and that is unethical when we are making the decision for our patients, right? Some women, when given all information, may still choose to use hormonal birth control, right? Again, we live in a free country. People should be allowed to make choices. But I would surmise that if women were truly given full informed consent about the fact that hormonal birth control, IUDs, can have significant side effects, can function as embryocidal agents. What do I mean by that? An embryocidal agent? Think about the word embryocidal. It's an agent that can kill an embryo. How? By preventing the implantation of an embryo at its earliest stages, right? When have had patients learn about that, they've been devastated to know, like, wait, I could be using a pill that I think is preventing pregnancy, but it's preventing pregnancy by preventing implantation of the embryo. That's caused significant just concern. Now, what is the data on that? How often, can hormonal birth control or IUDs cause the loss of an embryo at its earliest stages or result in the destruction of embryo? We don't know. There was a study by Dr. Kara Buskmiller that looked at women on hormonal birth control, and it found that 30% of women on hormonal birth control still ovulate. So if 30% of women on hormonal birth control are ovulating, but birth control pills only fail 10% of the time, right? That is, women get pregnant. What happens to that other 20%? Well, it may be that there was no sperm and fertilization didn't occur, but it is possible that fertilization has occurred, but the lining of the uterus is so thin, the embryo can't implant. And again, I believe that women and men should be given full informed consent. That is complete information about how family planning methods work, the possible, mechanisms of action, side effects, and risks, so that they can weigh whether or not it is worth it for them to use that method of family planning, or if they may want to choose another option.
Thank you for saying that, especially the informed consent part, because that's super important. If we really want women to be able to make a decision based on what information's out there, that is the best way to make a decision based on what you know versus what you don't know. A lot of women don't know how the hormonal birth control pill has hurt them or potentially killed an embryo that they weren't even aware that could happen. And again, the way that it works is that with the hormonal birth control thins the uterine lining. So if conception does happen, then the baby cannot implant. And so the baby dies. And also, I think that hormonal birth control can give a false sense of security, especially if a woman is sexually active. Obviously, we promote sexual activity after marriage. So a woman who is depending on birth control, thinking that, well, I can't get pregnant, and the fact that there's breakthrough ovulation that happens. And how many women who end up at the abortion facility were on birth control to begin with, and they weren't planning on a baby, and then they got pregnant, and so it feeds into abortion culture as well.
Yeah, absolutely. I mean, and the research exists by Planned Parenthood's research arm, the Guttmacher Institute. Based on their research, they found that over half of women who pursue abortion conceived when they were on birth control,
Wow.
right? So it's more than half of women who go for abortions were on birth control at the time they got pregnant. So you're absolutely right. Birth control gives this false sense of security that I'm not going to get pregnant. That is the purpose of birth control, when used for family planning, to prevent pregnancy. With fertility awareness-based methods, like educators educate, like the purpose of sex is twofold. It's for babies and for bonding, right? So when you have sex, you come together, you join, as one, and you're bonded to your partner. But the other purpose is to create babies, right? And it doesn't always happen, right? Because women aren't always fertile, but we understand that to be a fundamental purpose of the sexual union. So when couples are using fertility awareness-based methods, they know if they're taking chances and having sex during their fertile window, that there is a real possibility that a pregnancy can occur, right? And so they're going in more informed. They're taking a risk, but they're taking an informed risk. Whereas women who are taking birth control truly believe that they're not going to get pregnant. And when they do, it can often be a devastation, right? Because that's not what they had wanted. And now they don't know what to do, right? But Planned Parenthood is there with the answer, right? And I tell people, if birth control really worked as well as it did, when we think about Planned Parenthood and what Planned Parenthood's business model is, right? What is their primary business line? What brings in more money to Planned Parenthood than any other business? It's abortion, right? What is their second primary business line?
Selling hormonal birth control.
Hormonal birth control, right? If hormonal birth control really worked to prevent unplanned pregnancy and would ultimately reduce, unplanned pregnancies and reduce the number of abortions, do you think Planned Parenthood would market hormonal birth control as heavily as it did? No, they know. Their research shows that women on birth control will have unplanned pregnancies, and over half of women who pursue abortion will do so because they got pregnant on birth control, right? So again, women are free, couples are free to choose whatever family planning method they want to choose. I am not here to take away women's choices. I am here to educate people about the way their bodies work, about how family planning methods work, and about the full range of options that are available to them. And I think if more people were fully informed, we would see a tremendous surge in the number of people that are using fertility awareness-based methods and a significant decrease in the number of people that are using hormonal birth control. And in fact, we are seeing that, and it's across age ranges, it's across ideologies. I mean, there are so many people. There was a book called, I just blanked on it. It was a book about hormonal birth control and how more and more women are ditching the pill to use fertility awareness. And it was written by a secular woman, who frankly attacked the Catholic Church in the book because she was like, why did the church have to promote it? Like, this should be for every woman. And yes, we agree. This should be for every woman. And so we're seeing a significant increase in women, interested in using fertility awareness-based methods who come from all walks of life and who don't necessarily, use these methods for moral or ethical reasons, but just for health reasons, right? Like you said, organic reasons. They're not putting food with hormones in their body, so they don't want to put like devices with hormones in their body, and they want a better option.
Yes, no, thank you for that. And yes, this is evidence-based, this is science-based. And so people are seeing the green, it's called like the green revolution in terms of fertility awareness, because it is a healthy option without side effects. And as you mentioned, Planned Parenthood, this is their business model. Teach sex ed, teach the use of hormonal birth control, and then you'll have ladies end up there who are pregnant, who have unplanned pregnancies. And that's how the way that they feed their business model. So people need to be aware about that. And I wanted to just pivot a little bit with the time that we have left briefly on restorative reproductive medicine. We talked about the fertility awareness aspect of things, but a lot of women and couples, as you say, who struggle with infertility, these methods can help in a different way than IVF and some of the more conventional methods out there. So can you talk a little bit about how they differ from those conventional methods?
Sure. When it comes to addressing underlying women's health issues, absolutely. I mean, like I talked about at the beginning of the podcast with conditions like PCOS and functional hypothalamic amenorrhea, we're putting women on birth control. It's suppressing their cycle and giving them a withdrawal bleed, but it's not treating the underlying issue. And in fact, can often worsen the underlying issue, right? With polycystic ovarian syndrome, as I mentioned, it really is a metabolic disorder. And one of the common metabolic dysfunctions associated with PCOS is insulin resistance. And hormonal birth control can actually worsen insulin resistance. So by putting women on hormonal birth control, you're not treating that underlying issue. You need to address it by addressing the dysfunction. So with my patients with PCOS, the first thing I'm working with them on is lifestyle and nutrition and identifying if there's insulin resistance. And if there is, treating that medically with medications as needed. But it's so critically important. I mentioned endometriosis as one of the other two leading causes of infertility in women. Endometriosis commonly presents with painful periods. And oftentimes it will present in adolescence, and young girls will be put on birth control at an early age. Now, with endometriosis, and let me just define this for your listeners, since, again, this may not be primarily a medical audience. But endometriosis basically is a condition where the endometrial cells that line the uterus, right? The endometrial lining is what is built up each month in preparation for implantation of an embryo. And when you don't get pregnant and your body sheds the uterine lining and you have your period, it's the endometrial cells that line the inside of the uterus that are being shed. So it's normal to have endometrial cells, grow on the inside of the uterus every single month. But with endometriosis, those cells escape the uterus and they implant in other parts of the body. They may implant on the fallopian tube or on the ovary or on the bladder or in the pelvic wall. And they're hormonally responsive. And so women can experience significant pain associated with it. And with hormonal birth control, because it's suppressing the hormones, it does suppress the symptoms. And so the pain can get better, but it doesn't actually remove the cells or suppress the growth of the cells, right? So those endometrial cells that are implanting outside of the uterus may continue to grow and spread, right? And when we think about cells in our body that are growing or spreading where they're not supposed to be, what do you think of, Irina? Like, what do we call it when cells are growing where they're not supposed to be? Cancer. Exactly. Now, to be clear, endometriosis is not cancer, but it behaves like cancer. And we don't treat cancer by simply suppressing the symptoms, right? Sometimes we'll use chemotherapy to suppress the growth of the cancer. Sometimes we'll go in and do surgery to remove the cancer. And so when we give women hormonal birth control, we're simply suppressing the symptoms, but the endometriosis continues to grow. Such that when a woman wants to have a baby and she goes off hormonal birth control, her pelvic cavity, her abdominal cavity may be riddled with endometriosis. And endometriosis is going to cause a very inflammatory environment that's not hospitable for pregnancy and can lead to infertility. And this can be devastating. So the way we want to treat endometriosis is, first of all, to diagnose it, right? And it is a surgical diagnosis. So you really need to do surgery to identify and diagnose it, and then to treat it by removing it in its entirety. Unfortunately, most OBGYNs that are conventionally trained, they are trained to go in and remove like the big pieces of endometriosis, or they're trained to go in and burn the endometriosis. Now, again, when somebody has cancer, we don't go in and just remove the big tumors, or we don't burn the cancer. We go in and remove it all. But that's not how most OBGYNs are trained to treat endometriosis. So you really need to see surgeons that are specialized in endometriosis treatment, and they are few and far between. Dr. Young in St. Louis, Dr. Hemphill, Dr. Obst in Texas, Dr. Whitaker in Pennsylvania, certainly Dr. Hilgers in Omaha, Dr. Womack in Texas. There are surgeons, but they are so few and far between. And again, we try to list as many of them as we can in our FACTS, physician, clinician, and educator directory. But you need to have this diagnosed and treated. And what happens when you don't? Then you suffer. I currently have a patient, Anita. I'll share this, Irina. I'll share this story because I think it's a very impactful story. Like most teenagers, she had painful periods and at the age of 15 was put on hormonal birth control. She was put on different forms because she was dealing with side effect after side effect, but continued to stay on birth control. In her early 30s, she was actually experiencing such severe back pain that she pursued surgery for her back, only to discover that it wasn't a surgical back issue. A year or two later, she had abdominal surgery and was noted to have significant adhesions in the pelvic cavity, and was asked if she had ever had that investigated, which she had said no. She had simply been on birth control. At 35, when she got married and wanted to have children, she went off the birth control and was told, you likely have endometriosis and you're going to need to do IVF. And that was her option. She wasn't told that you could see a restorative reproductive medicine surgeon who could completely remove the endometriosis to support you to have a child naturally. In fact, she was told she would never conceive naturally. The IVF doctor that she saw did have her do surgery, where he removed like the big pieces of endometriosis and then proceeded with IVF. She had multiple rounds of IVF. She had 9 embryos created. She was able to carry 1 child to term, but the other 8 remaining embryos, a couple were transferred and the rest were told were not genetically sufficient enough to even warrant transfer. And so they're currently frozen in a freezer somewhere. And then she was told she needed to do another round of ovarian stimulation and egg retrieval to try again. Now she's 40 years old. So she's done IVF for 5 years and has one child. She came to me in November, and I saw her for the first time in December and discovered nutritional issues, insulin resistance. I treated both of those, and clearly endometriosis. I'm not a surgeon. I'm a family physician. I love what I do, but I'm grateful for my surgical colleagues. I referred her to Dr. Patrick Young. She had surgery in March, and she was pregnant 1 month later.
Wow.
With no ovulation induction medications, nothing other than treating the root underlying causes. And she looked at me, she's like, Dr. Duane, how is this possible? I was told I would never conceive naturally. And I mean, I was like, I'm sorry, like they simply didn't tell you the truth, right? Like, yes, you didn't conceive naturally. You needed to have these underlying diseases treated. But once we could restore your reproductive system to health, you were able to carry to term. You know, I had a patient with PCOS. Again, we did a lot medically, surgically to effectively treat her PCOS. And she conceived within 2 months of having, an ovarian wedge resection with Dr. Hemphill, which was phenomenal. And then a year and a half later, she conceived again by accident. She was like, how did this happen? We weren't even trying. And I was like, well, we restored your reproductive system and you reproduced. I mean, they were overjoyed, but they were just stunned because they were like, we had to work so hard to conceive. Well, the first time we didn't realize that it could be this easy. So infertility is rapidly increasing. The rates when we first started FACTS back in 2010, it was like 1 in 8, 1 in 6. Now it's up to 1 in 5. It's increasing. But the issue with infertility is it's not just a woman's health issue. I mean, both of those stories I cited, I did do an evaluation of the husband. There were treatments I implemented for the husband, that was necessary. Infertility, causes of infertility, 30% of the time, it's due to a female factor. 30% of the time, it's due to a male factor. 40% of the time, it's both. So we need to identify, address, and treat both male and female fertility. And again, that's one of the beautiful things about being a family physician is that I can care for both the woman and the man to identify and treat those root underlying causes of fertility. And I want to just point this out, Arena. When patients come to me, whether it's with psycho-related issues or infertility, especially with infertility, I tell them, my goal as your doctor is not to get you pregnant. I can't do that. Like, I am not the author and creator of life. I am a doctor that has been given, tools and an intelligence and a skill set to support your body. My goal is to restore your health, to optimize your reproductive health so that you can come together with your partner to hopefully conceive a child. And if that happens, to do whatever I can to support that ongoing pregnancy and the development of that embryo to allow you to hopefully have a healthy live birth, 9 months later. But I don't see myself like IVF doctors in the sense like I'm not creating life in a test tube. I am optimizing your health. And so many of my patients, including my patient who had PCOS, ultimately decided to have surgery, not for the purposes of having a baby, but to optimize her health. But the beauty is when we optimize health and we restore the body, it can do what it's designed to do. And that's what restorative reproductive medicine offers. It's not simply changing your diet or modifying your exercise routine. Yes, we absolutely integrate lifestyle changes, but it is identifying, diagnosing, and treating those root underlying causes and using modern medicine, using medications like metformin to treat insulin resistance, using low-dose naltrexone in patients that may have like chronic autoimmune or inflammatory conditions such as endometriosis to optimize the woman's health, and using surgery when indicated to restore the reproductive system to the way it was normally designed so it can function in a healthy, harmonious way to help a couple, achieve that long sought after baby or to restore the woman's health. I would love to say that every single one of my patients that have come to me for infertility have been able to conceive and carry to term. The reality is that's not the case. In the last 3 years, in the patients that I've cared for, I've had 39 who've presented with infertility and recurrent miscarriage. And of those, 34 of them have conceived. That's an 84% conception rate. Currently, our live birth rate is 57%, but we have a number of pregnancies that are ongoing. So I expect our live birth rate will be upwards of 60 to 70%, which is more than double what we see with IVF. And again, it's because we are identifying and treating the root underlying causes. Is it 100%? No. And so we often will talk with couples about other options for building their families as well, because ultimately I want couples to achieve the greatest gift that I've been given, and that's being a mother. But it's not up to me. And ultimately I recognize that, but I do whatever I can to support my patients and to train the next generation of physicians and medical professionals so more women and more couples and more people will have access to this life-affirming restorative reproductive health care.
We appreciate so much, Dr. Duane, all that you're doing to help educate as well as to help families have babies, etc., and really to get to the root cause of disease. And that's the difference, as you mentioned, between restorative reproductive medicine and fertility awareness-based methods and what conventional medicine gives us, which is a Band-Aid on top of a root disease, and that doesn't fix the issue. It actually creates more issues when you go to IVF, as you mentioned, and we will actually have this on other shows. Frozen embryos, the death of these embryos, families who still cannot conceive even after going through so many rounds of these other methods instead of getting to the root cause of the issue. And so this is super helpful. I want to close with the last question about what your vision for the future of fertility awareness and reproductive medicine is in the next 10 to 20 years.
That's a great last question, Arena. But before I address that question, I want to address one other topic that I think is critically important, and that is the topic of miscarriage. We were just talking about infertility, and while getting pregnant is something that matters to couples that are trying to building a family, carrying the pregnancy to term is ultimately what matters. And miscarriage is often the silent, unspoken about condition that affects so many women, and yet we don't discuss it. Miscarriage is defined as the loss of a pregnancy between 5 weeks gestational age and 20 weeks gestational age. After 20 weeks, we refer to it as a stillbirth. But what's important to note is that we know embryologically that the heart begins to beat at about 18 to 21 days post-fertilization, which is at about 5 weeks gestational age. So when a miscarriage occurs, what ultimately happens is that embryo's heart stops beating and that pregnancy no longer develops, and the life of that embryo is lost at its earliest stages. Now, I'm not sure if you realize this or even if most people realize that, but we don't actually track miscarriage as a cause of death, even though clearly it is a cause of death. The embryo's heart has stopped beating, the embryo stops developing, the life of that embryo is over. We don't track it as a cause of death as a vital statistic, which is very unfortunate because it is so common. The research shows that about 15 to 20% of pregnancies will end in miscarriage. And 15 to 20% may not sound like that big of a number, but you have to ask yourself, what is it 15 to 20% of? And it's 15 to 20% of all live births. So in 2022, there were 3.6 million live births in the United States of America. If you do the math, 15 to 20% of 3.6 million is 500,000 to 750,000 pregnancies ended in miscarriage.
Wow.
That is 500,000 to 750,000 embryos were lost at the earliest stages of life. If we actually track miscarriage as a cause of death, it would count as the third leading cause of death in America after heart disease and cancer. Now, we do so much in America to identify and treat and prevent causes of heart disease and cancer, and yet we do nothing to identify and treat underlying causes of miscarriage. In fact, the way we are trained in medicine is that we don't do anything to identify potential risk for miscarriage in a woman until she's had 2 or oftentimes 3 miscarriages. Now, I have 4 children myself. If someone said to me, you have to wait until you've lost 3 children before we figure out why you're losing your children, I'd be like, that's unacceptable. And yet so many women who are suffering in silence, having experienced a miscarriage, because we tell them, well, we don't want to tell people about the pregnancy until we know it's going to stick. Oftentimes these women are suffering in silence. I have sat with women and held their hands as they've cried because nobody's recognized the dignity of the life of that child that they lost And these women and these men suffer as well, because oftentimes there's that feeling of like failure. How have I not been able to protect my wife from experiencing this trauma? We need to train more doctors to be able to identify and treat miscarriage. And in fact, that is something we absolutely do. But more importantly, we need to educate couples. How can we reduce the risk of miscarriage? How can we reduce the risk of infertility? And the common denominator with both increased risk of infertility and miscarriage is age. So while we can't turn back the clock, I mean, I would love to turn back the clock 10 or 15 years and have a few more children myself. That's not possible. But what we can do is educate ourselves and educate our friends and our family members and our children about the fact that our fertility is a gift and it is limited. Our fertility is highest in our 20s, right? And our risk for infertility and our risk of miscarriage doesn't go up when we turn 40 or 45. It actually begins to increase at 32. And it takes another significant, drop at the age of 35. So many women and couples now are being told to delay pregnancy, establish yourself in your career, finish your residency training, buy your house, make sure you're financially set. And now you're 35 and your ability to have a baby is less. And now women are being told to freeze your eggs in your 20s and have babies when you're 30 or 40 or 45. Nobody's actually telling them, what is the success rate of frozen eggs or frozen embryos? There's really very limited data and it's not very good. So we're not giving couples, again, full informed consent. And the most important information that I think your listeners can walk away with is that the female cycle is a vital sign of health, that women can and should learn to track their cycle as a vital sign of health, beginning once they go through puberty. And then when it comes to family planning, we really need to embrace this whole concept of reproductive life planning. We have a lecture, a presentation on this in our CME course by Dr. Danielle Miller. We're going to have a new one by Dr. Summer Holmes Mason. Reproductive life planning is the whole idea that, we talk about our plans for our family when we're teenagers, when we're in our early 20s. Just like when we're teenagers and we're planning for our careers, we should be planning for our families and what do we want them to look like. If I want to be a doctor when I'm 30, there are things I need to do now as a teenager to make that happen. If I want to have 2, 4, 6 children by the time I'm 35, there are things I need to do now to make sure that's happening, starting with just monitoring my cycle to see if there may be underlying health issues that I need to address earlier through a restorative reproductive lens.
Yes, and the super important facts and information about that. And also that fertility declines for males as well. It's not just
Absolutely.
It's not just
Absolutely.
the women where it declines. And men think, well, I can have kids at any age. Well, it gets harder for men too, right?
Absolutely. Men's fertility also begins to decrease in their late 30s and their 40s. And while some men may be able to have health children later, oftentimes they can't. And again, a lot of it relates back to lifestyle choices. I mean, obesity is an epidemic, high blood pressure, drug use. These are all contributing factors to subfertility that people don't realize. They think they can do whatever they want in their teens and their 20s and then, have babies in their 30s. But the choices you make today can absolutely have a lifelong impact and on your ability to have children in the future. So let's switch to the future and my vision for the future. When I started FACTS in 2010, I started it because this was a topic that I had never learned about in medical school and that was not being taught in medical school. When people ask me, what do I envision for the future of FACTS? My ultimate goal is that there will be no need for FACTS in the future because this education will be integrated into the standard curriculum of every medical school and every nursing school and every midwifery program and PA program. So this is as a standard part of reproductive healthcare education. The reality is we are still a long way off, but the good news is we're starting to see change. Last year in 2024, I began a new position at Duquesne University's College of Osteopathic Medicine. Duquesne welcomed their first class of medical students in July of 2024. And that time, they also launched the Center for Fertility Awareness Education and Research, of which I serve as the director. And one of my primary goals there is to integrate education on fertility awareness-based methods at every level of the medical school curriculum. And November of 2024 and October of 2025, I have the opportunity to teach the full class of medical students at Duquesne University, all of them, about fertility awareness-based methods and cycle tracking, and how this serves as a vital sign of health, and how this is a tool that can help guide people's family planning decisions. This is incredible that this is now a part of a medical school's standard education. And I've had conversations with Benedictine College, which is hoping to open up a medical school, and with other institutions that are looking at integrating this into the standard curriculum. But to do this takes time and effort and energy. FACTS is a small nonprofit that has done amazing work with a skeleton crew. And it's been in part due to the many volunteers, the teachers, the fertility awareness educators, the RRM physicians that volunteer their time to teach our students. And it's due in part to the many faithful supporters, donors, and benefactors that regularly support the work of FACTS so that we can grow our organization and create more content to educate more medical professionals and students. So I would say to your listeners, if you want to help us achieve our vision to have a physician-led team in every community that can provide fertility awareness and restorative reproductive medicine in your community, please consider supporting the work of FACTS and referring your medical friends and colleagues and doctors to FACTS About Fertility to learn more and to become a part of our community. That's how we're going to change the culture so that fertility is viewed as normal and healthy, and so that within every community there is a physician-led team trained in fertility awareness and restorative reproductive medicine to provide the care that every person deserves when it comes to reproductive health.
Thank you so much, Dr. Duane. This is so important, and it affects all of our lives. Our fertility
Everyone.
is part of our basic health, and you are blazing the path forward, not only for couples everywhere, individual women, etc., but also for training the future generations. So thank you so much for all that you do, and we'll definitely have you back on the show to touch on some of the other topics that we would love to have you on to talk about.
You're welcome. I would love to join you again. Thanks, Serena.
Thanks so much for listening to this episode of the Bioethics Babe Podcast. If you've enjoyed this content, please subscribe to my YouTube channel and your favorite podcast platform, and share with your friends and family. Also check out bioethicsbabe.com for the latest episodes and resources.